I would like to invite Arianne Blanco up to present the case. Arianne is one of our advanced trainees at the PA Hospital. She's a second-year advanced trainee, and she has an interest in pursuing further training in infectious diseases and the immunocompromised host. She completed her MBBS at the University of Queensland, a Bachelor of Science with a major in microbiology at the University of Manitoba, and she has obtained her FRACP in general and acute medicine. So I'd like to welcome Arianne. Just while we're waiting, I did have one question for Peter earlier. Peter, you mentioned oral mouthwashes for your diagnosis. Have you had much experience with nasopharyngeal swabs? We saw Patrick in the room, so I wonder if you might comment on this from Pathology Queensland as well. But would that be equivalent? A lot of our patients don't want to give us sputums or don't want a bronchoscopy.
No, there's a lot of reports of that. Most of it's oral washes. We sometimes use those as well, but they're difficult to interpret because we don't necessarily know what they mean in the modern context. But nasopharyngeal formal nasopharyngeal specimens, we don't really get much at all because they're tricky to get. They do in pediatrics, but no, I don't think they've been, as far as I can tell, been examined for new sisters.
So I think it was Marion Woods a while back did a kind of semi-formal evaluation of this, and we've never properly validated it in the lab, but it has kind of slipped into clinical practice and it has proved useful. So we do accept nasopharyngeal swabs for PCR, for PCP, PJP, although we obviously encourage a formal specimen if we possibly can, but it certainly has proved useful when it's challenging to get a proper specimen.
Thanks, Patrick. I might also invite Burcu Isler down to be part of the panel for this case discussion. And we will kick it off now, and hopefully we won't keep you too far away from lunch, but we will try our best to get through.
Now I'll go through my presentation quickly so you can all get to lunch. And Andrew, feel free to stop me at any stage if you'd like anything discussed. So I'll discuss a case that was seen at the PA earlier this year. She was a 54-year-old lady with end-stage renal failure secondary to diabetic nephropathy. And in January of this year, she underwent a kidney transplant from an unrelated donor with implantation into the left due to iliac vessel calcification, but it was an otherwise uncomplicated procedure. And you can see her induction and maintenance therapy listed there for those who are interested. And her background history was remarkable for type 2 diabetes, for which she was on insulin therapy, as well as chronic liver disease secondary to hepatitis B, for which she was on entecavir. Now, about a little bit over a week after her initial transplant surgery, she had a slight rise in her creatinine, and you can see there the acute drop in her hemoglobin as well. She underwent further investigations, and on an ultrasound, she was actually identified to have two significantly large hematomas that were actually causing mass effect on the vessels of her transplanted kidney with evidence of impaired perfusion. So she went on to have an emergent evacuation of the hematoma with exploration for a source of bleeding with a renal biopsy. Now, she intraoperatively was found to have a large paranephric hematoma with some bleeding from the renal artery. Overall, though, the appearance intraoperatively, there was no concern about the appearance of the transplanted kidney itself. She did have a renal biopsy, though. As you can see, she did have evidence of borderline T-cell mediated rejection. Now, post-operatively, she did have very good urine output, pardon my spelling, but her renal function actually still remained quite slow to recover, despite a trial of pulse methylprednisolone and a repeat ultrasound post-operatively about 4 days, showing resolution of the perinephric hematomas without any other significant abnormalities. Now, at this stage, she was going through some routine care, had her IDC removed and a trial of void done, with a urine MCNS that was just done routinely rather than based on symptoms. And as you can see there, she was noted to have isolated carbapenemase producing Enterobacter cloacae. You can see her initial sensitivity panel there.
So Aaron, I might just stop you there and just maybe canvass the audience, and just for sort of show of hands, who's going to treat this? So how long post-transplant are we now, Arianne?
About just under 2 weeks.
So Samuel, I think it would be relatively routine practice to treat within sort of the first month or two when you isolate something from the urine, even though we talked about asymptomatic bacteria. Is that? Yep. So no one put their hands up. Well, the patient survived, so we'll keep going.
All right, so this is just pardon. So this is just obviously summarizing that she was otherwise at that stage well, had absence of symptoms, fevers, or any clinical evidence of pyelonephritis in either the transplant or her native kidneys. Now, she was empirically at that stage commenced on ceftazidime avibactam as in combination with aztreonam empirically on the 17th of the 1st.
So, Arianne, we might just pause for there. Borju, I know your PhD was really in carbapenemase genes. Do you want to maybe comment on sort of this approach or what other approaches might be for this pathogen?
Of course, I think it has commenced on appropriate empiric treatment because a certain type of carbapenemase, which is metallo-beta-lactamase, is prevalent in Australia. And to be able to treat metallo-beta-lactamases, we need to combine ceftazidime avibactam with aztreonam. Ceftazidime avibactam is a new antimicrobial, new beta-lactam-beta-lactamase inhibitor, as you probably all know. It inhibits carbapenemases, the avibactam component, which is a beta-lactamase inhibitor. It inhibits most of them except the metallo-beta-lactamases. So to be able to add in anti-metallo-beta-lactamase activity, we need to have aztreonam on board. And aztreonam is, it's an old beta-lactam actually. We don't use it anymore. It has a very narrow spectrum, but its biggest advantage is being stable to metallo-beta-lactamases. It can be hydrolyzed very easily with other narrow spectrum beta-lactamases, but I think having avibactam on board prevents aztreonam being hydrolyzed. So together, this is a great combination, I think, and what's appropriate in this patient's case.
Yeah, thanks. Monica, I might just come to you. Would that be an approach that you would have done in your location as well, or would you have used anything differently?
No, I think that's probably what we would have done. We've done that several times in our transplant patients. I think because of toxicity issues, it's actually quite a good option. We really all steered away from things like colistin, and I didn't see the aminoglycosides. Was there any aminoglycoside you could have used? Obviously, it's not optimal in this patient population.
She did have sensitivity to amikacin.
Amikacin, but yes, again, try and steer away from that in this population.
And Patrick, you're in the lab. Why don't you ever tell us if it's susceptible to aztreonam and avibactam? We're always in the dark here.
So it's actually a trick question. So if you set this up for ceftazidime avibactam, there would always be resistance. So they usually have these imp carbapenemases, so they look resistant if you test them by themselves. Aztreonam, you may be lucky. Sometimes it's susceptible to aztreonam on its own, but usually if they've got AMCs and ESBLs and other things, that would inactivate that. So you really need to do synergy testing, and really there is no standardized method for synergy testing. We're trying to develop some. There are some, you can do sort of crossed E-tests and sort of piled on top of each other and all kinds of things, but nobody really knows how to interpret them and how reliable they are and consistent. So to get that for clinical level reporting in a diagnostic lab, CLSI, UCAS, all these people have no published method that's yet reliable, but we're working on it.
So I think just to clarify, the ceftazidime is not doing anything here. So the best testing would actually just be aztreonam and avibactam together. Probably, by broth microdeletion, but there's no breakpoint set for that. But you can ignore ceftazidime as sort of a synergy, I suppose. But we might continue with the case, Arianne, if that's okay.
As I sort of outlined, so the decision at this stage, she was seen by ID and the decision was to treat as a lower urinary tract infection post-IDC. However, further imaging was recommended to ensure that there was no deep-seated infection within the native kidneys themselves. Now, I'll just include the CT scan here, which hopefully I can play. And you can see here, I'll just pause, that she had sort of multifocal hypodensities all throughout her transplanted kidney, with also a comment on, as you can see in the report there, a small perinephric collection.
All right, so I might just open up to Borju and maybe to the group now. And we talked about durations in transplant pyelonephritis. Is obviously slightly different, but what would you be thinking now, Borju, in terms of treatment?
So the sensitivities are back. I think as expected, it is resistant to ceftazidimab avibactam, as well as to aztreonam. Yeah, I think, I mean, it is even resistant to cefiderocol, which is another new antibiotic which could potentially have activity against carbaphenamase producers, but unfortunately resistant. So I think I would go with ceftazidimab avibactam aztreonam, noting that, I mean, the literature shows that this combination is usually effective, but it may fail as well because of the resistance profile. So used in combination, duration-wise, I think treatment of resistant organisms is not greater than the ones that are susceptible. So I would go with the same duration. But given that there's a collection, I think we will have to continue longer or try to drain that collection.
So what would you be thinking if it's undrained in terms of sort of rough duration?
Undrained abscess, 6 weeks.
Yeah. And in the audience, higher, lower, 6 months? Is there a different facility?
Actually longer than that, I think. I mean, very early post-transplant, rejection, quite a lot of hypodensities, and take a while to recover very resistant.
Yeah, so probably 6 weeks and rescan type approach, I think, which most of us would do.
All right, so we did continue on the combination of ceftazidime avibactam as well as aztreonam. Now, at this stage, this is about a week after that initial scan, was the first time that our patient had started to develop fevers as well as worsening abdominal pain. She went on to have a repeat CT scan, which hopefully, again, this will play. And you can see that there has been now quite a significant increase in the size of that perinephric peritransplant collection. You can see the measurements there from the key image. So I think at this stage, she underwent further investigation. So I'll just highlight here that her renal function was still quite slow to recover. And at this stage, she was actually getting intermittent hemodialysis as well, post-transplantation. She had a repeat urine sample for what it's worth. And at that stage, she identified a second multi-resistant organism with a VAN-A, vancomycin-resistant Enterococcus faecium. She did go on, oh, sorry.
I was just going to say we are very welcoming at the PA, and we do like to let our patients go with multiple sort of presents.
At this stage, she was actually also commenced on linezolid in addition to her other antimicrobials. She did go on to have a radiologically guided percutaneous drain, and the samples from that actually re-isolated the Enterobacter coacae, the CP isolate that she previously had. However, it didn't actually isolate her BRE at that point. So she continued on linezolid as well as the ceftaz, avi, and aztreonam. Now, following drainage, she continued to have slow recovery, but was actually otherwise improving from the infection perspective. And I've just included her CRP trend there to show that biochemically, she actually had quite a good response. And sort of 27th of February was kind of nearing in about the 4-week mark of her therapy with relatively good suppression of her CRP throughout February. Now, however, she did actually have repeat imaging throughout her course. And this is the CT, which I'll demonstrate shortly, was actually one that was on about the 23rd of February, so near the end of her course. And you can see that she actually still, while a bit more subtle, she still had quite a pocket evidence of ongoing hyperdensity and a bit of a pocket of infection there.
Is Arianne, and just to clarify, she was in hospital this whole time?
This entire time. So she's about almost 2.5, 3 months into her admission at this stage.
Yeah. And I just saw Jason pop into the room. I know, Jason, you've been doing a bit with outpatient antimicrobial therapy. Do you know much about the stability of avibactam at home and whether that would be an option?
I can't really say. I'm actually under embargo, but we have actually done, we actually have the results of a study where we're looking at ceftazidime and avibactam, but I can't tell you what the results are. But
Yeah,
don't, I'll just leave it there.
You heard it here first, Brett. Groundbreaking.
So I guess at this stage, this really just begs the question. We've got an immunocompromised host who's really just freshly been transplanted, who has clinically and biochemically had good response to her therapy and drainage, but with persisting changes on her CT scan. So I guess this really just comes around to beg the question about duration of therapy at this point, particularly in somebody who has been in hospital for a while. And this particular therapy was not something that could be facilitated in the community. So if she were to continue on therapy, she'd have to remain as an inpatient.
So I guess that's a question. And does anyone want to commit and put their hand up to say that they would stop the patient now?
And the functional scan, if I like a case for a gallium scan.
She didn't actually have a PET or a gallium scan after this that I saw.
Yeah, I think we were short on gallium at that point in time, but we didn't consider that. Thanks, Arianne. I think at this point it had a drain in it. Is that right?
Yeah, so she did have but she'd had the drain already initially done a few weeks prior to that. So this scan was done about 4 weeks after the initial drainage. That was not done at that stage, no. So I'll just end off with my last slide just to kind of close the loop. So despite the ongoing changes on imaging, the decision was actually made to trial a cessation of therapy at 6 weeks of treatment, given that Mrs. Vi was well with clinical improvements outside of imaging and a suppressed CRP, but also sort of taking into account a few pragmatic things, which as I mentioned before, inability to sort of continue with therapy in the outpatient setting. This is a lady who wasn't from Brisbane. She's from somewhere up near the Gold Coast. I think she was, at this stage, my understanding, quite desperate to get home after being in hospital for 3 months. And so far, to date anyways, as far as I'm aware, her care has been transferred elsewhere now. She remains well off the antimicrobials with no relapse anyways in the CPE intravector infection.
So I think quite an interesting case, and obviously lots of different opinions about how we possibly could have managed that or done it in hindsight. But at the end of the day, I think probably as good an outcome for the patient that we could have expected, and probably quite fortuitous based on what we've talked about. So I would just like to thank all the speakers for presenting in this session, and to Burcu and Arianne for the case discussion as well.